Hi, this is hour 2 of the medically complex disease management training, and today we're covering vital signs, and I think this will go through, let's see, today goes through blood pressure exercise guidelines. So we're going to start with the vital signs slide, and this is the key part. This is a key part of this training. Taking vital signs is not only the job of nursing, it is our job as well. We can't avoid this anymore. We are the only ones who see what our patients, what the residents' blood pressure, heart rate, respiratory rate is doing during activity. The nurses see what it's doing when they're sitting in a chair, what their heart rate and other vital signs are doing when they are at rest in their wheelchair, in bed, when they are sitting supine. But we're about the only ones who see what happens to their vital signs when they stand, when they are active, when they are exerting. So we have got to get comfortable with taking their vital signs. We've got to learn to get over the fear of listening, well, not only the vital signs that I mentioned, but also listening to breath sounds, which we're going to do later. But today we're talking about heart rate, respiratory rate, heart rate. I'm being distracted by my kitten trying to get in the room here. So we need to practice it and become comfortable with it so that we can take their blood pressure when with sit to stand, with their eating, with their ADLs, with ambulation. Another thing is to be able to document their response to physiological challenges. If it isn't documented, you didn't do it. We need to be able to also report what we have observed with activity to nursing. Can most patients feel when their blood pressure is too high? That's why it's called, hypertension is called the silent killer. No, most people can't feel when their blood pressure is too high. We need to be able to take their blood pressure and see what's happening. When an anxious COPD patient wants to cut therapy short because he says he just doesn't think he should do too much exercise today, do we have a good basis on which to make that decision, or are we going on the patient's report? We need to be able to take their heart rate, their blood pressure, and help them make an informed decision. They may still refuse, but we need to be able to tell them, your goals are to get home so that you can live with your husband and not have to live here in the nursing home. Your blood pressure is 120/80. Your heart rate is 78, and I know you're breathing fast, but that may very well be to anxiety, and I understand that you're nervous because you're short of breath, but your other vital signs are very stable, and I would like you to push on through this and try to continue standing here at the counter and making your sandwich, or continue brushing your hair, or I'd like you to walk a little further, because that's the only way we can help you become stronger and improve your endurance so that you're able to go home with your husband, blah, 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 and do some education, as opposed to us not having the ability to teach them because we don't know. So we think, oh gosh, she says she doesn't feel good, she better sit down, so we let her sit down. The other part of that, being Debbie Downer, is if the patient had a bad event in therapy and the lawyer asks you, has her blood pressure ever plummeted like this before? Has her heart rate ever become erratic like this before? Are you going to be in a good legal place saying, I don't know, I never checked it till she collapsed? We're working with sicker patients than ever before, You need to get to know what's normal for your patient as far as their heart rate response, their blood pressure response to exercise and activity. As I said before, the patients at a resting rate with a nurse, they may well have documented that they have a regular heart rate at rest, and that it's never been documented that their heart rate becomes irregular with mild exertion, and it may not be that unusual of a response for them to exercise, but because we've never documented it before, and they have a bad episode in therapy and their heart rate becomes irregular, and they have go into V-tach and end up in the hospital, and whatever scenario happens, because we haven't documented it and maybe even checked it out with the physician, and he says, yes, that is typical for this patient. It makes it appear that we were not monitoring, and we weren't. We weren't monitoring our patient and what was going on. So we need to know what's going on. The other thing is, do we know where to find our patient's pulse? As we'll see later, some people's pulse is stronger on one side than the other. Some people have a very faint breast pulse anyway, so if your patient has an event and you're feeling all over their wrist trying to find their pulse, is it weak because they've had an event, or was it weak to start with? Another point is this is where our knowledge of functional measures such as the Borg rate of perceived exertion scale, the METS levels, O2 sats, the ventilatory response index ties in with these vital statistics. I'm sorry. Yeah, I'm sorry, my cat is distracting me again. Vital statistics, and tying that into that their standing tolerance, their ambulation distance, their oral intake. So they ate 85% of their meals. So they ambulated 120 feet. So they stood for 6 minutes. What was their physiological status as a result of doing all that? Was their blood pressure 200 over 100? Was their heart rate 120? How did they respond to that physical taxation as a safety aspect, but also progress? So the first time they stand for a certain period of time, they have kind of an exaggerated blood pressure response or an exaggerated heart rate response. But as we continue to do exercises with them and their endurance gets better and they become better conditioned, their blood pressure response becomes more in line with what it should be expected. Their heart rate, their respiratory rate doesn't increase as much, and it becomes much more in line with a normal physiological response. So vital signs, why do they matter? Taking their pulse, blood pressure, respiratory rate, O2 sats. Why aren't you taking blood pressures, pulses, respiratory rates if you're not? This is kind of a personal question. Is it because you don't feel comfortable with it? If you don't feel comfortable with it, you need to practice, 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 practice. Practice with your husband and your children at home. Practice with each other at work. Take the equipment home. Tell somebody you're taking it, of course, and then practice at home. Become comfortable with it. Do it repeatedly, and it won't take practicing that long to become comfortable with it. The blood pressure thing, the difficulty with it is working that little thing that you have to twist to tighten it and loosen it, and knowing how much to tighten it that you clamp it off enough to stop the air from seeping back out, but not so tight that you can't release it, and how much above their systolic, their usual systolic, to pump it, how fast to let it off. It's just a matter of becoming acquainted with it. It's not something you can't overcome. That you don't have time. you do have time. It is part of assessing your patient's response to an intervention that you performed. When you walk somebody, when you do an ADL with somebody, you assess quickly how they responded to that. How did they do? How did they align their buttons? Did they get their pants on straight? Did they, when they ambulated, how was their did they cross their legs? Did they take a long enough step? You do that kind of assessment. We need to know and document how they physiologically responded to how far we had them walk or how much longer we had them stand. It is part of our skill in deciding to progress or hold somebody back. So we do have the time, and it is an expectation of us professionally. The medical world, the legal world expects us to make the time to assess the effect of our interventions. The next slide, we have already talked about this in the, I think we did. Maybe I'm confused. In the vital signs for the old person compared with the younger adult, the older person's temperature is lower. So for someone 85 and older, their temperature may be, their normal core temperature may be 95 to 97 degrees. So they may be running a low-grade temperature at 99 degrees or 98 degrees. Their pulse rate is in the 70 to 75 beats per minute range. Respirations are a little faster because their lung tissue is not as compliant. The rib cage is stiffer. They may have kyphosis, so the rib cage is not moving outward as easily, so they have to breathe faster to get in the amount of air that they need. Blood pressure may be higher, again, because the tissues aren't as compliant and the vessels are stiffer, so the blood traveling through the vessels is traveling through at a higher pressure. The normal heart rate, this is mostly vocabulary, normal heart rate is 60 to 100 beats per minute. Under 60 beats per minute is referred to as bradycardia. Over 100 beats per minute is referred to as tachycardia. How to measure someone's pulse. At the wrist, right where, if you have the patient bend the wrist, you put your two fingers right inside the radius bone, right in between the bone and that first tendon. And there'll be a little indentation there. And you have to give some pressure, but not too much pressure, because if you give too much pressure, you'll occlude the vessel. And then you'll feel a pulse there. And then you want to count it for a full minute, because the reason you want to count it for a full minute is because you want to feel for any irregular heart rate. And if you just do it for 10 seconds or 15 seconds, you may not appreciate any arrhythmias. Now, if you have trouble, I'm holding my arm up here. If someone has a weak pulse, you may not be able to feel it. So you may have the person drop their arm to their side, so the gravity will assist, a more bounding pulse. Now, you can just have descriptors for what their pulse is like. Is it regular? Is it irregular? Is it consistently irregular? Or is it inconsistently irregular? Is it strong? Is it weak? Another term I've heard is thready, a thready pulse. If you can't feel their pulse at the wrist, you can feel it at their inside of their elbow. Just here you would feel it inside of the ulna bone, so the inner elbow, and between there and the biceps tendon. You should be able to feel it there. If you can't feel it there, You can feel inside the upper arm. Can't feel it there, you can feel it at the carotid artery at the neck. Okay, don't know what happened there. The normal heart rate to response. Normal heart rate response to exercise. Some of this may seem self-evident, but I do want to go over it because when we're talking about abnormal response to exercise, it gets kind of murky, and you just have to keep in mind what's the normal response to exercise, and it keeps it clear in your mind. As you work harder, when you're out in the garden, when you're running, when you're pushing the lawnmower, your heart rate gets faster. But as you work harder, your heart rate gets to a certain level and then plateaus out. It doesn't start to change in rhythm, and it doesn't go so fast that it just becomes it doesn't go off the deep end. There's a linear increase in your heart rate as the workload increases, and then there's a plateau in your heart rate as the maximal exercise capacity is reached. So that is the normal heart rate response to exercise. Now there are certain medications that inhibit the heart rate's response to exercise, and one of them we're going to talk about that I'm going to mention are beta blockers. And adrenaline, you all know what adrenaline is. That's the fight or flight hormone. That makes adrenaline makes the heart beat faster, makes your heart beat harder. Beta blockers are a medication that blocks adrenaline. So it makes beta blockers make the heartbeat slower and with less force, and thereby decreases blood pressure. Beta blockers are prescribed for high blood pressure, for arrhythmias, for angina, but they're also for congestive heart failure. Because of those attributes of beta blockers, it's often prescribed for someone with congestive heart failure. But it's also prescribed for people with anxiety, migraines, tremors, glaucoma. So it's prescribed, those medications are prescribed for a lot of diagnoses. Now, there are other medications that are beta blockers, but some that are easy to recognize, and I point these out because a lot of our patients are on them. Medications that end with OLOL, O-L-O-L, like metoprolol, atenolol, propranolol, and medications that end with pril, P-R-I-L, like lisinopril. Those are beta blockers. So when you're looking at the list of medications and you see those drugs, those are beta blockers. Now, one thing I want to say about beta blockers is so they inhibit the heart rate's response to exercise. How much? So their heart rate won't change at all, or how much? It blunts the heart rate response to exercise by about 20 to 25%. Okay, beta blockers blunt the heart rate response to exercise by about 20 to 25%. So if you're working somebody on the new step or the FTF, or walking or standing or in the shower, it's not like their heart rate's not going to increase at all. It's just going to be blunted a little bit. Okay, abnormal heart rate responses to exercise. Somebody can have an unusually low resting heart rate. It can be possibly due to sinoatrial node dysfunction or ischemia. An example of sinoatrial node dysfunction I want to give you so that you'll connect it with something. When I did home health, I had 2 patients, and that was their issue. I was referred to them because they were referred for physical therapy because they were falling. And so I went and did my evaluation. We did strengthening exercises for the legs, did the balance stuff, walked outside on the grass, on asphalt, and all the kinds of little balance things could think to do, and they did well. And no episodes of falling, no imbalance. We did all the kinds of little musculoskeletal things could think of. And so, getting ready to discharge, they fall again. And it comes out that they had a sinoatrial node dysfunction. They needed a pacemaker. So what was happening is their heart rate was going along fine, and then they would have an electrical abnormality in their heart. They weren't getting enough blood because they had an irregular heart rate, and they would faint and pass out and fall. That's what was causing the falls. Had 2 patients that way. So that's all, something you should consider. Or ischemia, that their heart is got so many bad areas in it that they can't pump out enough blood. They've got, or I'm sorry, well, that could be something too, but the electrical activity in the heart is not right, and they have an abnormal heart rate. Another abnormal heart rate response to exercise is that they have a resting heart rate of greater than 120 beats per minute, and that may indicate acute illness because fever can cause tachycardia. Another abnormal heart rate response is a rapid increase in heart rate with minimal workload. That can be seen in somebody who's a couch potato, so they're very deconditioned, or in somebody who has significant cardiac disease. So you're going to have to evaluate that from their history and from your evaluation of their response to exercise and to increasing activity loads. Little or no rate increase with increased workload, possibly due to cardiac ischemia, or that they're on cardiac medications, or that they have a pacemaker, that their heart rate is set to top out at a certain level. They could have significant changes in rhythm with exercise, complaining of palpitations. So it gets to a certain stress level, which could be exactly what it sounds like, emotional stress or physical stress, and they start to have a flutter. And on that case, usually all it takes is for them to settle down again, and their heart rate will come down to a resting level again. One note, it's very important to monitor vital signs until they return to normal. You can see irregularities in the cool down phase, and if they do have irregularities here, you need to document that and report it to the nurse. Okay, let me catch up with my notes here. Okay, the Carvonen formula for determining the aerobic intensity of exercise. We won't need to do this on every patient, just like not every patient has dementia, not every patient has urinary incontinence, but there may be cases that you need to know how far you can push them as far as their heart rate in order to be safe. If you look at the top of this page, the whole page is devoted to this. The top of the page says determining the aerobic intensity of exercise, and the formula starts out, generally the maximum heart rate is estimated as the following. The formula in the middle of the page starts out THR equals MHR minus RHR times percent T intensity. Okay, that formula is correct, but the example is not right. So we're going to follow the formula, and so I need you to get out your pencil and keep up with what I'm saying, because I do think it's important that you have this down correctly. Okay, so you start with, it's really not that hard, and I am terrible at math, so if I'm saying it's not that hard, you can get this. Okay, so you start with 220, and why it's 220, I don't know. Some exercise physiologists figured out this formula, so we're just going to go with it. So you take 220 minus the person's age, okay? Then you're going to take that and subtract their resting heart rate, and that's where this example is wrong. They don't So they don't give us a resting heart rate in the example, and they don't subtract that off. Like I say, the formula is correct, but the example is wrong. So under example number 1, they did correctly 220 minus 85, because that's our example guy's age. They come up with 135. Now you need to subtract off a resting heart rate. So let's say the guy's resting heart rate is 70. So they're off to the right side of 135. Write minus 70, and in parentheses write resting heart rate, your example resting heart rate. 135 minus 70 equals 65. Now we are to the next part of the formula, the THR equals MHR times percent training intensity. Now is when we take that number and decide how hard are we going to do we want to work this guy, and that percentage is going to be determined by the physician or by us, just like when we do the FTF training on the Nautilus equipment or high intensity training with any kind of equipment. We're going to decide, do I want to work him at 100%, at 80%, at 50%, 40%. For this example's sake, they said let's work him at 70%. So we're going to take that number we got from the first calculation, which was 65, and we're going to multiply that times 70%. Okay, so 65 times 70%, and that gives us 45.5. Now, per the formula back up at the top here, we have to add the resting heart rate back in. I know, it's crazy. Now we add the resting heart rate back in, so it's 45.5 plus 70, and that gives us 115. So our training intensity is going to be 115 beats per minute. So that is going to be our aerobic intensity of exercise for this man. Now sometimes the doctor will say, or we will decide, we're going to exercise in a certain range. So let's say we've got someone that we are concerned about because of their health, and we want to exercise them. We want to keep their heart rate between 60% and 70%, or 55% and 75%, or 70% and 85%. So you'll do that calculation twice and come up with two numbers, so that we'll say we're gonna keep his heart rate, or his exercising heart rate, between, and I'm just coming up with numbers off the top of my head, we're gonna keep his exercising heart rate between 95 and 115 beats per minute. If any of y'all have trouble with this, and I have just blabbered my way into blabbered you into confusion, call me, okay? But I do want you to be able to calculate training intensity, heart rate, okay? Because I had a patient just the other day who we needed to calculate this for safety, because he is in very poor condition. Okay. All right. Blood pressure is defined as the cardiac output times the total peripheral resistance. Okay. Think of it as a garden hose. How skinny or stiff your hose is, and how high you're turning on the water at the faucet. So how much water you're forcing through the hose, and how stiff or skinny your hose is. Normal blood pressure has typically been defined as 120 over 80, but new research is saying that it is really better if it's down around 110 over 70. The diastolic blood pressure is the bottom number in a blood pressure reading, and that's the amount of pressure your heart is under when it's at rest between beats. The normal diastolic pressure is between 60 and 90 millimeters of mercury pressure. Systolic blood pressure is the top number in a blood pressure reading, and it's the amount of pressure your heart generates when pumping blood. and that's during systole, or contraction of the heart. And normal systolic blood pressure is between 95 and 140 beats millimeters of mercury pressure. So we're saying, if you take both of those ranges, we're saying that normal blood pressure is between 95/60 and 140/90. And so that's the low end of normal and the high end of normal. When you're taking a blood pressure, it's a little, there are a little better guidelines than what's given on this slide here. You want to wrap the deflated blood pressure cuff around the distal upper arm. You want to feel for the pulse, which is, like I was saying before, is on kind of the inner side of the soft side of the arm, the inner arm. And then you put the stethoscope over that brachial artery, and sometimes your cuff, oftentimes your cuff will kind of hold it in there. And then you're going to pump up the cuff, and you're going to take the cuff, you're going to pump it up, not really high, because that will, number one, hurt, and it'll give you an inaccurate reading. You ideally want to know what their blood pressure is, and then pump it up 30 above that. The better you get, the less high you need to take it above their systolic pressure. But 30 above that would be okay. The American Heart Association makes important points for clinical blood pressure measurement. The patient should be seated comfortably with their back supported and their upper arm bared without constrictive clothing. Their legs should not be crossed. The arm should be supported at heart level, not hanging down by their side. So if they're sitting and you're standing, you should take their arm and support their upper arm on your iliac crest, and kind of clasp their arm should be at rest. They should not be holding their arm up in the air for you. Kind of clasp their arm between your arm and your side. The bladder of the cuff should encircle 80% of their arm circumference, and the bladder of the blood pressure cuff is not the whole blue cuff. We're talking about the little bladder that's inside the cuff. That should encircle 80% of the circumference. So if it's too big, you're going to get an inaccurate reading. And if the cuff is, and if the bladder is too small, and like they're obese, and the bladder only covers this much of their arm, it's going to be an inaccurate reading. The mercury column should be deflated about 2 to 3 millimeters per second. So it should come down at about this speed. Now, it shouldn't be so slow that you feel your heartbeat as it's coming down, but it also shouldn't be shh. You're not going to get an accurate reading that way. And neither the patient nor the observer should talk during the measurement. So really, we need to have an assortment of blood pressure cuffs in the department for the very large patient and for the very tiny patient. There needs to be, and they are on Beach. You can get a pediatric cuff, you can get a regular cuff, and you can get an extra large, or sometimes it's called a thigh cuff. I've seen both of them on there that way. And when you're listening for the sounds, you're listening for the first sound, and it should be a clear whoosh. Sometimes there's kind of a muffled sound. It's not that. When you're listening for the first clear whoosh, and that's a whoosh, and you start listening for that, and then when you stop hearing that sound, that's your diastolic pressure. Okay, and then you see a picture, and that's not being taken correctly because his upper arm is not held horizontally. Love it when they don't give a correct picture. Normal blood pressure findings with exercise. The systolic pressure, it should, just like with heart rate, it should increase with an increased workload because the engine's having to work harder, so the pressure should go up. But it should flatten out as maximum work capacity is reached. And I wish they wouldn't even say decreases slightly, because we're just talking a couple of millimeters of mercury pressure decrease. So it flattens out as maximum capacity is reached. Normal blood pressure findings with diastolic pressure, it should demonstrate no change or very slight, so it should stay within 10 millimeters of mercury increase. It should not, their diastolic pressure, we don't want it to increase any more than 10 millimeters of mercury, and that's a key number there. If you have less play, less room for increase in the diastolic pressure than you do systolic. So abnormal blood pressure findings with exercise, abnormal blood pressure findings, that there's little to no response with increasing workload, that there's a slight fall, then it abruptly rises, or it starts to rise like it should, and then it abruptly falls. So this is what I was talking about earlier when we were talking about normal responses. Sorry. We were talking about normal responses. If you can just remember what's normal, then it makes it easier when you think, now what's abnormal? There should be a gradual rise, and then it should flatten out. So if blood pressure starts to rise and then drops off, that's not normal. Or if it starts to fall and then rises abruptly, or rises with increased workload, that's not normal. Or if it doesn't rise at all, that's not normal. And then abnormal finding with the diastolic pressure, if it increases more than 10. If it increases more than 10. Or it rises a little bit and then doesn't go back down. So blood pressure exercise guidelines, exclusion, I'm just going to make it simple. Exclusion guidelines, and these are not incorrect, 200 over 100. Blood pressure of 200 over 100, we're not going to exercise them. So it's their last day of assessment. It's their last day of assessment, and we've got to get those minutes. Their blood pressure is 200 over 100. Sorry, we're not going to see them because we're not going to make them have a stroke, cardiac failure, heart attack. No, we're not going to see them. Precautions. The precaution range is 160 over 90. And what does that mean? So we're precaution. What are we going to do with them? We're going to do things that they may do anyway. They're going to go to the bathroom. They're going to go eat. They're going to get dressed. They're going to move around some. So we're going to maybe do some lower extremity exercises, and we'll talk about why we'll do lower extremity later. And we may walk a little bit. We may do a transfer if it's not too difficult, and we're going to constantly check their blood pressure. When I say constantly, that'll be somewhat dictated by what's happening to their blood pressure each time we take it. Is it staying pretty steady? Is it continuing to rise? But if it's continuing to stay around 160 over 90, then we don't have to take it as you know, every 2 minutes like we would if it's continuing to rise. But if I bring them down to the department and I am having them do some leg kicks, which is not difficult on the heart at all, shouldn't be. And I'm having them do some leg kicks, and they're sitting, and I take their blood pressure, and now their blood pressure is 164 over 94, and that shouldn't be happening at all. So I let them rest for 2 or 3 minutes. I take their blood pressure, and it hasn't changed much. It's still 164 over 92. So I have them do some ankle pumps, then I have them do some marching in place. Now their blood pressure goes to 168 over 96. I'm stopping. You know, I mean, we've done almost nothing of any challenge, and I'm going to take them back to their room and say, you know, here's what we've, you know, Nurse Ratched, here's what we've done, and their blood pressure has had this response. Let's see. Okay. Well, I can't believe it. Oh, the warning signs and what to do about them. Warning signs and what to do about them. Okay. There is a... I'm sorry. The warning signs and what to do about them. There are a couple pages of that in your manual. Cardiopulmonary monitoring, normal and abnormal findings, and then warning signs and what to do about them. Those are pretty good. As I read them over, there are some that I'm not comfortable with. When I had done this course years ago, I had Dr. Patty Gillette. She's a cardiopulmonary, that was her area of focus when she did her PhD at Bellarmine. And we had come up with a list of, if this happens, call the doctor, get emergent care. Or I'm sorry, if this happens, get emergent care. If this happens, call the nurse and have them be checked out before we see them again. And if this happens, let them rest, but it's not requiring immediate physician care. And I am going to send this to the RPCs and make this available for you that way. This is what's in your manual is pretty good, but some of them I don't think are have you taken an emergent enough position, like discomfort, pain, or pressure in the center of the chest, in the throat, or arms following exercise. It says stop, rest, and take your pulse. If your physician has ordered nitroglycerin, take as recommended. Consult your physician before resuming exercise program. Well, that could be, you could be having a heart attack, and I don't want to be that nonchalant about my reaction to discomfort, pain, or pressure in the center of the chest, throat, or arms. I want to get the nurse on that right away, treating it like it's a heart attack. If someone has 6 skipped beats in a minute, that could be a sign of ventricular tachycardia, which is a serious event and needs to be, that requires emergent care. So I would like to send this, where's my little camera? I would like to send this to you. So be looking for this form. I'll put it up in front of, there we go. Be looking for this form to come to your RPCs, and keep this in the gym. Put it on the back of the bathroom door if it opens to your gym. Put it on a binder ring and hang it on your parallel bars, so that if something happens, you will know, is this serious that I need to do something right now, or is it just mean we worked a little too hard and I'll take a little easier next time. Reasons to terminate an exercise program. If their systolic pressure, blood pressure rises more than 20-25 millimeters of pressure compared to their resting rate. If their diastolic pressure is greater than, it says 105 for sure. 100 is what I feel more comfortable with. And if while at rest there's a 15 millimeter of mercury drop in systolic, or a 10 millimeter mercury drop in diastolic from their baseline. Okay, so I know it sounds like a lot of numbers, but basically we don't want their systolic to rise more than about 25 millimeters of mercury. Their diastolic to rise more than 10. There should not be a drop of more than 15 after they've done their exercise and they're resting. There shouldn't be a drop of more than 15 in their systolic. There shouldn't be a drop of more than 10 in their diastolic from their baseline. The do not exercise precaution is 200/100. The be careful guideline on blood pressure is 160/90. And then refer to the warning signs list that I'm going to send you, or this one in your book about if this happens to your patient during exercise or as a result of exercise, here's what to do. And I don't want you to be scared to work with your patient. On the other hand, or quite the contrary, with me, I feel more comfortable knowing what's the worst that can happen and what do I need to do about it. And then that's my comfort zone. If I know this is where I need to stay, and if I do this, my patient will be safe, then I know my boundaries, and feel safer working with my patient and pushing him to maximize his rehab. So that is all we're covering for this novel. And thank you very much for your attention. And if you have any questions, please call.